Hi, everyone, and welcome to today's session. My name is David Odij. In this lecture, we'll be exploring medications used in the management of pediatric integumentary disorders. Understanding medication involves knowing drug classes, their uses, and safety measures. Nurses must consider patient-specific factors, potential side effects, and interactions. This knowledge ensures effective and safe patient care, aligning with best practices in pharmacology. Pediatric integumentary disorders encompass a range of skin conditions affecting children, including eczema, impetigo, and dermatitis. Understanding these conditions involves recognizing symptoms, such as rashes or lesions, and implementing appropriate treatments. Nursing considerations include monitoring for infection, educating caregivers on skin care, and ensuring adherence to prescribed therapies to promote healing and prevent complications. Pediatric integumentary disorders encompass a range of skin conditions affecting children. These include eczema, psoriasis, and dermatitis, each with unique symptoms and treatment protocols. Point: understanding these disorders is crucial for effective management and improving patient outcomes. Early diagnosis and tailored interventions can significantly enhance the quality of life for affected children. Mupirocin is used topically for impetigo and methicillin-resistant Staphylococcus aureus colonization. It's applied topically and works by inhibiting bacterial protein synthesis. Watch for local irritation and teach families to apply gently and prevent cross-contamination. Triple antibiotic ointment containing bacitracin, neomycin, and polymyxin treats mild impetigo by killing bacteria with potential for allergies. Instruct caregivers to clean the skin before applying a thin layer. Penicillins, like penicillin and nafcillin, are used for severe impetigo or pyoderma, given orally or IV. Their mechanism is cell wall inhibition, leading to bacterial death. Common side effects include GI upset and rash, so it's important to complete the full course and check allergy history. Finally, cephalosporins, such as cephalexin, also treat pyoderma and work similarly by inhibiting cell wall synthesis. Remind caregivers about possible cross-reactivity in children with penicillin allergy. Vancomycin is used for methicillin-resistant Staphylococcus aureus skin infections via intravenous, inhibiting cell wall synthesis. Major concerns include nephrotoxicity and Redman syndrome, so close monitoring of renal function and infusion rate is essential. Point: chlorhexidine is a topical antiseptic used for antiseptic skin cleaning. It disrupts bacterial membranes but can cause dryness and irritation and shouldn't be applied directly to open wounds. Point: next is the bleach bath, a diluted sodium hypochlorite solution used for children with recurrent MRSA infections. It acts as an antiseptic but may cause dryness or irritation. Proper dilution and avoiding contact with eyes are important safety points. Finally, for carbuncles and furuncles, treatment involves incision and drainage, sometimes with systemic antibiotics. The main reminder for caregivers and students is never squeeze lesions and always use sterile technique during procedures. This slide focuses on medications for pediatric fungal skin infections. First, topical azoles, including clotrimazole, miconazole, and ketoconazole, are used for tinea corporis, tinea pedis, and ringworm. They work by inhibiting ergosterol synthesis, which disrupts the fungal cell membrane. Side effects include mild burning or itching. Teach families to apply a thin layer and keep the area dry. Ketoconazole 2% shampoo is used for mild tinea capitis. It reduces fungal load on the scalp but can cause irritation. The shampoo must stay on the scalp for 5 to 10 minutes before rinsing. Selenium sulfide shampoo is also used for tinea capitis and dandruff. Remind caregivers that it can stain fabric and should be rinsed thoroughly. Point. Cyclopyrox comes in cream and nail lacquer forms and is used for onychomycosis. It works by disrupting fungal DNA replication. Treatment can be long term. Lastly, allylamines like terbinafine can be given orally or topically for fungal infections, including tinea corporis or pedis. Because it may cause liver toxicity, liver function monitoring is important, and alcohol should be avoided. Topical azoles like clotrimazole and miconazole treat tinea infections by disrupting fungal cell membranes. Apply a thin layer and keep the area dry. Point. Ketoconazole shampoo reduces scalp fungal load. Leave for 5 to 10 minutes. Selenium sulfide decreases fungal replication but may cause dryness. Cyclopyrox disrupts DNA replication, requiring long-term use for onychomycosis. Here we have medications for more severe or systemic fungal infections. Systemic azoles such as fluconazole and itraconazole are used for chronic or step-down therapy. Their mechanism is inhibition of ergosterol synthesis. Side effects include GI upset and liver toxicity, so it's important to check liver function and avoid use in pregnancy. Echinocandins, including caspofungin and micafungin, are intravenous antifungals used for resistant systemic infections. They inhibit beta-glucan synthesis in the fungal cell wall. These drugs require hospital monitoring due to risk of liver dysfunction. Polyenes, such as amphotericin B, treat severe systemic fungal infections. They bind ergosterol and cause fungal cell death. However, major side effects include nephrotoxicity, fever, and chills, requiring slow infusion and kidney monitoring. Point. Finally, nystatin is used for oral candidiasis and skin fold infections. Patients should swish and swallow the oral suspension and avoid eating for 30 minutes afterward. Acyclovir and valacyclovir are used for herpes simplex and shingles. They inhibit viral DNA synthesis, and early initiation is key. Hydration helps minimize side effects like headache or nausea. Point. For weeping herpes lesions, Burau solution, silver nitrate, and saline compresses provide symptomatic relief and help prevent secondary infection. Point. For warts due to HPV, treatments include cryotherapy, laser, and curettage, which physically destroy affected tissue. Pain and possible scarring should be explained to families. Point. Finally, medications such as cantharidin, imiquimod, or tretinoin are used for molluscum contagiosum and warts. These stimulate an immune response but may cause irritation, so cautious application is important. Parasitic skin disorders like pediculosis and scabies are caused by lice and mites infesting the skin or hair. These conditions lead to intense itching, irritation, and secondary infections if untreated. Management mainly involves topical medications such as permethrin, benzylbenzoate, or malathion. Ivermectin may be used in resistant or severe cases, along with hygiene measures to prevent reinfestation. Here we discuss treatments for pediatric scabies. Permethrin 5% cream is first-line therapy for children over 2 months old. It is applied over the entire body and washed off after 8 to 14 hours. Side effects include mild burning or irritation. It's important to treat all close contacts and ensure full body coverage. Crotamaton is an alternative but may be less effective. It can cause skin irritation and should be avoided on broken skin. Ivermectin, given orally, is reserved for refractory cases or scabies with extensive excoriation. It may cause GI upset or dizziness, and it is not recommended for children under 15 kilograms. Dosing is weight-based. This slide reviews medications for head lice in children. Permethrin 1% lotion, known as NYX, is the first-line treatment. It is applied to the scalp for 10 minutes, then rinsed. A repeat dose is given after 7 to 10 days. Mild irritation is common. Pyrethrin plus piperonyl butoxide is an over-the-counter alternative. Avoid in children with chrysanthemum allergy. For resistant cases, malathion 0.5% may be prescribed. Because it is flammable and irritating, it should be used in a well-ventilated area and not in children under 2 years old. Atopic dermatitis, AD, is a chronic inflammatory skin condition characterized by itchy, red, and swollen skin. Management includes topical corticosteroids to reduce inflammation, applied 1 to 2 times daily. Point. Topical immunomodulators like tacrolimus are used for flare-ups, while oral antihistamines provide pruritus relief. Monitoring for side effects like skin atrophy and sedation is crucial for effective treatment. Topical corticosteroids of varying potencies reduce inflammation during flare-ups. They should be used 1 to 2 times daily and only short-term on sensitive areas like the face or diaper region. Watch for side effects such as skin atrophy or pigment changes. Topical immunomodulators, including tacrolimus and pimecrolimus, are steroid-sparing agents for children 2 years and older. They can be used on the face and flexural areas. Mild burning is common. To manage itching, oral antihistamines such as hydroxyzine or diphenhydramine are often used at night due to their sedating effects. Non-sedating antihistamines like loratadine are better for daytime symptoms. Wounds in pediatric patients require careful management to prevent infection and promote healing. Topical corticosteroids like hydrocortisone reduce inflammation, while topical antibiotics such as mupirocin treat minor infections. Point. Systemic antibiotics, including amoxicillin clavulanate, are used for severe infections. Proper application and monitoring are crucial to avoid complications and ensure effective treatment. This slide covers medications commonly used for pediatric wounds. Topical corticosteroids such as hydrocortisone or betamethasone help reduce inflammation and irritation, but they should be used short-term to avoid masking infections. Point. Topical antibiotics, including mupirocin, bacitracin, and neomycin, help prevent or treat minor infections. Watch for hypersensitivity reactions and remind caregivers to apply with clean hands. Point. For severe or widespread infections, systemic antibiotics like amoxicillin clavulanate or clindamycin may be prescribed. GI upset is common, and completing the full course is essential. Point. Some wounds involve fungal infections, requiring oral antifungals such as fluconazole, terbinafine, or itraconazole. These medications carry a risk of liver toxicity, so monitoring liver function is important. Point. For pain control during wound cleaning or suturing, topical or intradermal anesthetics like lidocaine may be used. Careful dosing is especially important in children. Point. For discomfort, analgesics such as acetaminophen or ibuprofen are given based on weight. They help reduce both pain and inflammation. Lastly, we have supportive wound treatments. Bureau solution or alkaline compresses help reduce itching and inflammation. Apply for 15 to 30 minutes, but avoid overuse to prevent irritation. Recombinant growth factors like bicaplermin gel help stimulate granulation tissue in complex wounds. These should only be used under specialist supervision. Point. Finally, vac therapy or vacuum-assisted closure helps wounds heal by applying negative pressure. It improves granulation and removes excess fluid, but requires close monitoring for skin irritation and proper seal placement. Thank you for your attention. We hope this presentation has enhanced your understanding of wound care medications and their applications. Your engagement is invaluable.